Welcome to COVID-19, Keeping Up with the Moving Target. I'm your moderator, Faith Rogers with DKB Med. Thank you so much for joining us today. We are pleased to welcome today our expert faculty members, Dr. Chuck Vega. He's Health Sciences Clinical Professor at UC Irvine Department of Family Medicine, Assistant Dean for Culture and Community Education, as well as the Director for the UC Irvine Program in Medical Education for the Latino community. With us today, we also have Aima A, Assistant Professor of Medicine in the Division of Infectious Diseases at Vanderbilt University Medical Center. Dr. Vega, Dr. Ahonkhai, thank you so much for joining today.
Thanks for having us. Thank you, Faith, and great to be here. Thanks for everybody for joining us.
These are our faculty's disclosures. This educational activity is supported by an independent educational grant from Regeneron Pharmaceuticals Incorporated. All activity content and materials have been developed solely by the planning committee members and the faculty presenters. Today's learning objectives are to describe the current management strategies and identify potential treatments for mild to moderate COVID-19, evaluate the best practices for managing patients with COVID-19 using monoclonal antibodies and other agents, describe current management strategies and identify potential treatments for COVID-19 patients requiring hospitalization, and assess the impact of COVID-19 on Black, Latinx, and American Indian and Alaska Native communities and the factors contributing to health disparities in these communities. As a note, this is all current as of Friday, June 18th. So if you're watching this on demand, please do refer to NIH and IDSA guidelines for the most contemporary guidance. Okay, and with that, I would like to hand this off to Dr. Vega. Thank you, Dr. Vega, for your time today.
No, my pleasure. Thank you, Faith. And you're getting dangerously good at those monoclonal antibody pronunciations. I may ask you to pinch hit for me in a few minutes if I have trouble with the old Vanderbilt. That's the one. But it's great. Thanks to our audience for taking time out of your day to be with us. I know that everyone's busy, and so it means a lot, but this remains such an important issue for us. So I'm going to be speaking more to an introduction to COVID-19 as we know it today, and focusing more on the outpatient treatment, which is really where my practice in Santa Ana, California is based and focused. And I'm going to be handing off to Dr. Ahonkhai to talk about her experience, particularly on the inpatient side and what treatment options there are there. So we're really going to focus on therapeutics today, but put in your questions, please, into the question box, because it's always stimulating. We're going to certainly try to leave some minutes at the end for discussion. We are going to focus today on some issues around why we are seeing so much higher rates of COVID-19 in our African American, in our Latinx, in our American Indian, Alaska Native populations, and why outcomes seem to be worse there as well. So we are going to try to wrap that all in as we go through. But as the outpatient person, I'm here to remind you that in most cases of COVID-19, while we had a field hospital, likely you had a hospital that was overstuffed, maybe it was just a couple, 4 months ago with patients with COVID-19, most patients have more mild and moderate illness, which could be managed as outpatients. And we now have more treatment options for them. This is just a nice level setting graphic because it includes a bunch of different information. It has the viral load of SARS-CoV-2 RNA, and it correlates it with symptoms. So that red line correlates with symptoms. And as you can see, one of the real insidious things about SARS-CoV-2 is that you get that increasing viral load before you have symptoms. So you have that pre-symptomatic spread, which is a real problem. On the backside, that viral load takes a while to go down. It takes the course of a week, 2 weeks. You might see patients who are still shedding virus several weeks later, particularly if they're very sick. And so there's another chance for more infectivity associated with SARS-CoV-2. And then the symptomatology, it varies. It does vary from patient to patient quite a bit. But I think one thing that always stood out to me about SARS-CoV-2 is that there is this chance for a more inflammatory reaction that can occur on day 6 of illness, day 8 of illness, day 10 of illness. That's that cytokine storm where it's not so much the infection as the body's response to it. It's really promoting a lot of the pathology, particularly respiratory pathology that can put patients in the hospital in the ICU. We have different treatment options available. Anything you want to think of using as an antiviral, you want to get it on board as soon as possible. So generally, antivirals work best if you start it right away. Convalescent plasma, we're not going to talk about too much today because it's not used in as many centers. There has been some negative studies showing that it doesn't really make a difference. But if you look at studies which really focused on high titer plasma, so and especially when it's given to folks who don't naturally mount a strong immune response, maybe they're a lot older, maybe they're on chemotherapy or on other immunosuppressives. There, I think convalescent plasma can still have some role, but we're not going to touch on it too much today because we have a lot of stuff to cover. And then immunomodulators can be used more during that inflammatory phase of illness. So in terms of risk for severe illness and who we want to really watch out for, and this is part of our triage system when we're taking in somebody with suspected COVID-19, there's a lot of factors. These are the patients I see every day. I don't see a lot of well patients. I see a ton of folks with heart failure, diabetes, COPD, and in my practice, given that I'm older and been there a while, I see a lot of folks with advanced age past 65 years too. So I'm not going to belabor this, but I think that a couple of highlights, in the past 2 months, it's really been shown that type 1 diabetes and type 2 diabetes are both independent risk factors. Obesity is definitely a risk factor for more severe illness with COVID-19. In one meta-analysis, COPD stood out as the most significant risk factor in terms of comorbid illnesses. And generally, these comorbid illnesses are additive. Probably just like my practice, you don't just see patients with diabetes, but they have obesity and they have heart failure and they're 68 years old, et cetera. And so we can't forget that age is a substantial risk factor for complications. I get very nervous about folks in assisted living because we know that when we think about mortality in COVID-19, there was a huge outsized proportion of folks who lived in assisted living facilities who died from COVID-19. So that's a public health crisis right there. But you also want to keep in mind that American Indians, Alaska Natives, Black or African American patients, Latinx patients, all are at higher risk for incidence of COVID-19, for hospitalization due to COVID-19, and for mortality due to COVID-19. And there's been a lot of discussion as to why this is, but at this point, those facts are not in dispute. The causative factors are something we're going to talk about today, and it makes me think about the fact that many individuals with COVID-19 are used in the emergency department. It's something we're really trying to guard against in my setting because we are trying to be good stewards. I think this past year has taught us a ton about stewardship of healthcare resources, from PPE to drugs that can work, and then really to, especially at the level of the emergency department and inpatient units and ICU, really trying to keep patients out of those spaces so we have enough room for the sickest of the sick. But so many individuals in my community are used to using the ED. I'm a primary care physician, and unfortunately, so many individuals in my community are used to using the ED as their primary care office. So when they get sick, that's where they go. That's where my parents went. So therefore, I think there's something of they don't have the access to care, and they don't have the preventive care. So these are not folks who are getting their vaccinations. They're not getting routine screening. Diabetes uncontrolled, hypertension uncontrolled, asthma uncontrolled, and that's why we see higher rates. So it's not and I think we'll hit on this several times. It's not a genetic trait. It's not, that there's some physiologic difference. When we look at people of color and the response to SARS-CoV-2, it really comes down to the social determinants of health that we have groups of people who are living in multi-generational households, which are cramped. We have a lot of folks in that frontline service industry. And then they have more comorbid illness. So what would we expect to happen? Of course, more patients of color are going to go to the ED. And of course, they're more likely to be hospitalized and unfortunately die of COVID-19. So these are, I think, are known disparities that have been magnified during this pandemic. But let me get back to routine care of just of our outpatients. First we're going to try to monitor symptoms. We try to check in with patients with COVID-19 through telehealth every couple days, 3 days max, until they're really starting to improve quite a bit, and then we can let them go a little bit longer. So monitoring symptoms right now, as of a year ago when there were no pulse oximeters available, I was really struggling. Like, well, see if you can climb your stairs, if you have stairs at home, but many people didn't. That's a good sign. I was trying to organize some different techniques. Now pulse oximeters are much more widely available commercially and cheap. We are discharging patients from the hospital with them, for example. But they need a good pulse oximeter, a good thermometer. Don't forget the basics, thermometer, because they have a lot of patients on day 10 of illness telling me, yeah, I feel better, but I still get sweats and chills. And I'm like, don't know what to do with that, because they should not release you from isolation if you still have fever. So they should be checking their temperature and their oxygen saturation routinely, and they should know how to use it. So if you get a pulse ox of 68%, don't call. The first move is not go to the ED. The first move is, put it on a different finger, squeeze a little bit, turn it on and off, and so all those tricks we normally do. And I think the rules for isolation and the rules for quarantine were just switched, so now you don't have to follow these if you are vaccinated, so that's a big benefit. Another way we can promote vaccination, but I have a feeling you're probably familiar with those rules overall. Let's go into antibody-based therapies, because they have become a hot topic. They are effective, and it's a story that continues to be told, both in terms of the outcomes they're achieving in clinical trials, the number of products that are available, and how we're using them, particularly as variants start to spread around the United States. It's important to pay attention to this therapeutic area. But do think of them like antivirals. The sooner you can get them on board, the better. My goal is 24 hours. Do I often achieve this goal? That's 24 hours since the onset of symptoms. Do I often achieve this goal? I do not. But I often get close, and I have gotten them within 1 day of the onset of symptoms in several patients. And that made me feel really good. Those patients did better. One actually ended up hospitalized, but she had a lot of comorbid illnesses. She did fine though, survived, and is doing better now. Thankfully. So what about the data on these agents? So let's start with bamlanivimab plus etesevimab. This got its original emergency use authorization for bamlanivimab as monotherapy back in November. And so you may wonder, wait, what's etesevimab? I mean, why is it being added in? Well, this cocktail actually binds to different epitopes of the SARS-CoV-2 spike protein. So essentially the idea is you'll get greater efficacy, especially as variants start to spread, by targeting different sites and different receptor proteins on that antigen. And so it got its EUA as a combination drug in February, and that's as a result of the BLAZE trial. BLAZE is an ongoing phase 1 through 3 trials looking at these products like bamlanivimab plus etesevimab. And you can see, if you compare it to a lot of folks who present with COVID-19, younger age, a diverse patient population, but still many are sick, and that's pretty typical of the practice I see. Originally, BLAZE's outcome was viral load at 11 days. It wasn't the best outcome, and bamlanivimab alone never actually achieved that outcome versus placebo, that it actually had a significant reduction in viral load by day 11. A lot of patients, because they had more mild and moderate illness, got better by day 5, and their viral load was already decreasing, whether they got placebo or bamlanivimab. But combined with etesevimab, it actually achieved that target of reduced viral load versus placebo at 11 days. But something more important emerged, even with bamlanivimab as monotherapy, and it was a much more patient-centered outcome. These patients had less healthcare use. They were less likely to use the ED, less likely to use the hospital. And especially, it was important for folks at high risk. So those with risk factors such as obesity, diabetes, COPD, et cetera, did even better with the monoclonal antibodies. This is another result from the phase 3 cohort of BLAZE. This is using the lower dose of bamlanivimab plus etesevimab. Again, a significant reduction, now looking at the outcomes of hospitalization or death, very important patient-centered outcomes, with bamlanivimab outperforming placebo by 87% in this study. Another product, casirivimab plus imdevimab. Now this one got its EUA, its emergency use authorization, in November 2020. And that's a result of this particular trial, another placebo-controlled trial. We're just looking at outpatients with moderate COVID-19 here, diverse patient population, younger age, still a lot of underlying risk factors, and again, reduced healthcare use. Especially, remember, it was critically important, back in November, especially all the way through the winter when we were seeing at the height of the pandemic with so many cases, that we really wanted to keep patients out of the ED, out of the hospital. And monoclonal antibodies certainly played a role in that. They're superior to placebo in those outcomes. And they are associated with few adverse events. I'll just try to address this briefly. So, one of the real limitations of using monoclonal antibodies is they have to be given in a setting. It's an IV infusion. It's given over an hour usually, and the patients have to be monitored during the infusion, and they have to be monitored for an hour afterwards, because there is the risk of some kind of severe event, such as anaphylaxis. So there has to be a crash cart available. There has to have folks who know how to use it, and that's been a real limitation on the use of these agents, particularly in under-resourced settings. Where do you find infusion centers? Do we have enough crash carts? Do we have enough personnel? And so that's been a limitation. And I think that a lot of health systems have worked really hard to repurpose parts of the ED. They repurpose part of a dialysis center, and they're able to get the folks with expertise. It's worth it. In terms of the actual risk, it seems very low of a severe adverse reaction. In the EUA, for bamlanivimab, ethnicity, they described that there was 1,000 patients that were followed for this outcome. There were 4 severe events. Only one required epinephrine, and everybody did okay. As these monoclonal antibodies were rolled out nationally, I was very curious. Gosh, are we going to see this spike in severe adverse events? No, we have not. And other than that, they are very well tolerated. There's not a lot of side effects associated with the use of monoclonal antibodies. So going back to casirivimab plus indevimab to continue that story, the phase 3 portion, now we're talking about a larger group of patients, 4,000 of them. And these are patients at high risk for complications of COVID-19. And you can see, again, whether using the lower dose, which has really been the dose that's been approved, versus the higher dose, still a significant reduction in either hospitalization or death versus placebo. In this study as well, the casirivimab plus indevimab was associated with a 4-day reduction in the duration of symptoms. And so relatively new, the EUA was changed, so really emphasizing use of the lower dose. And very importantly, in settings when an IV is not feasible, it's reasonable to consider using it subcutaneously, which would be a big load off of all that logistical stuff, which made giving these monoclonal antibodies more difficult to do. And we do have a new agent on the box. It's Trivamab, and so this one has a more recent EUA from May 2021 based on this phase 3 trial of 583 patients. And you can see, again, a significant reduction with Trivamab versus placebo for the risk of hospitalization or death. And so this trial was stopped early because of clear superiority of Trivamab versus placebo. And it's also being studied, maybe if we combine different monoclonal antibodies together, we could actually get greater efficacy. So those studies are ongoing. And that's important because we are facing these variants. Of course, we're going to get to variants. We're going to discuss variants today. Right now in the U.S., it's really that B117 is the predominant variant in circulation, followed by well behind by P1. But there's a lot of concern about the 617 variant. That's the one that was originally reported in India, rather. And if you're wondering, well, what happened to bamlanivimab as monotherapy, this table shows you. So with these variants, we saw greater resistance to bamlanivimab as monotherapy. Still can be effective, especially for B117, which is, again, that's the predominant variant in the United States right now. You don't have to worry about that particular variant. It's sensitive to all the different monoclonal antibodies. But bamlanivimab plus ethnicity is running into trouble with P1 and this B1351. Whereas casirivimab, Trivamab, so far don't seem to be affected by the variants. But it is obviously something that we continue to watch. Big question is if 617, which is the one, again, originally described in India, has a much higher rate of transmissibility. If that becomes more prevalent in the United States, what do we do then? We'll have to follow the data. So it's important to stay tuned and to have your trusted resources and follow them when we're thinking about how we employ monoclonal antibodies. But what really hasn't changed are some of the core elements of who should get these monoclonal antibodies. So at the age of at least 12 and over, outpatients only, not for inpatients. There was just a trial that was published where there was a press release about they did have improvement in a subset of patients who were inpatients who weren't responding to the virus in terms of their own immune systems. That's great, but we don't apply that now. We don't apply monoclonal antibodies outside of a study setting for inpatients. For outpatients, if they're over 12, if they have one of those high-risk conditions, which are really common, I've got a slide coming up on that in a second, they have to be within 10 days of the onset of symptoms. But remember, the sooner you can get these antibodies on board, the better. And as I mentioned, you have to monitor the patients and have the ability to have a crash cart available. So age over 12, high risk for complications, outpatients. Those are the keys to remember. And in terms of the high risk conditions, many of my patients will qualify for one of these conditions. I'm not going to read the list, but I think that this is actually a simplified list, believe it or not, versus what they had previously, where you had to look at age and then risk factors. And so now it's a lot more straightforward. One group I'll call out especially here is I manage a lot of patients with cerebral palsy, with severe Down syndrome. I would rank those folks in this high risk category. If they have neurodevelopmental disorders, it's going to be a risk factor for complicated COVID-19. Get them monoclonal antibodies and get them the vaccine, of course. So here's the NIH and the Infectious Disease Society of America recommendations. Generally similar. They don't recommend one therapy over another. They haven't really had a chance to react to Trivamab yet, but these guidelines have had different iterations and they are evolving. So watch the space. But right now, using monoclonal antibodies, they are underused for those high risk patients over 12, who are it's something we should be doing more of, actually. That said, unfortunately, sometimes I feel like I fail. I hate to get a little paternalistic, but I take it on myself personally. And patients do end up in the ED, and they do wind up hospitalized. Luckily, we've got great colleagues like Dr. Ahonkhai to help take care of them. And so I'm going to hand off the next part of this discussion to her.
Great. Thank you so much, Chuck. So in this section of the talk, we're really going to review the role of antivirals and immune modulators in the treatment of hospitalized patients with COVID-19. But I do want to make one point that's important, because as we're in a different phase, clearly, of the pandemic, where people are not, afraid to go to hospitals, and people are going to hospitals for their other, flares of COPD or CHF, and they may have mild COVID-19 disease in that case. And so there are some patients who are hospitalized for reasons other than COVID-19 who may still be eligible for the outpatient kind of protocol for management. But what I'm focusing on here are people who are admitted specifically for their COVID-19 disease. So we'll start with Remdesivir. So Remdesivir is a prodrug. It diffuses into the cell, and it is metabolized into an active drug, which acts like this molecule we've all heard about, ATP, adenosine triphosphate, an analog of that. And so it actually incorporates into the RNA chains of SARS-CoV-2 using its polymerase as it's replicating or translating that virus in the cell. And it incorporates as this kind of a mimic of ATP and stops that process of translation, or stops that copying process. So that's how Remdesivir actually works in the cell. And the data that supports the use of Remdesivir comes from this ACT-1 trial. This is a multi-site, multi-country trial. One of the first we heard positive results of, randomized over 1,000 patients to Remdesivir or placebo. And it was stratified by disease severity and location. And the findings really showed that the primary endpoint was time to recovery. So people who were randomized to Remdesivir had a shorter median time to recovery of 10 days compared to 15. And that, when adjusted, was rate for recovery that was increased by 29% in the Remdesivir group. They also looked at mortality outcomes in this study. You can see on this slide that at 15 days, there actually seemed to be a mortality benefit of Remdesivir, but this was lost when that was followed out to almost a month at 29 days. So probably no real significant mortality benefit, but definitely improvement in time to recovery. So this figure shows the rate of recovery in the treatment arm. That's the blue line, the Remdesivir line, compared to control in the red line. And you can see differences in the two lines here. This is looking at proportion recovered over time. There's no overlap in the confidence intervals of those two lines. So there's a clear distinction between those outcomes with people in the remdesivir arm doing better. And then when we look at some important subgroups in this analysis, you can see the same distinction in the red versus blue lines in the top right panel, C. And that's important because that's the group of patients who were receiving oxygen. So of all of the subgroups, you can tell just by kind of stepping back and looking at this graph that the patients who were receiving oxygen had the most benefit. And if you look at the graphs at the top left, bottom right, basically the other three, you can see that there is some overlap among all of those lines. The one in the bottom right is people who were on mechanical ventilation or ECMO. You can see those lines nearly overlap, and so there really was no benefit of remdesivir in that group. As far as safety in the trial, there were the serious adverse events were about 24% in remdesivir, 32% in placebo. Grade 3 and 4 events were similar across the two. And the most common non-serious adverse events occurred in at least 5% of patients. So it's fairly well tolerated, although people who had really severe kidney disease, really low GFR, were really not studied here, so it's not recommended for use in those populations. So this slide shows the data, the recommendations from both the NIH and IDSA, and Chuck referred to these groups earlier. They both have their own websites where they update these recommendations. But you can see the NIH here recommends remdesivir for patients who are hospitalized and require supplemental oxygen. So that's the important point. If you remember the visual of the red and blue lines, it's the oxygen patients who were on oxygen who really did the best with remdesivir. And IDSA, similarly, they're recommending remdesivir for hospitalized patients with severe disease who are requiring supplemental oxygen, but not on mechanical ventilation or ECMO. Remember, those were the lines were on top of each other, so they really did not benefit. Okay, so moving on to the immunomodulators for inpatient management of COVID-19. And this is thinking about things that modulate the immune system, so things like steroid, things that impact interleukins, and other cytokine pathways. So this slide summarizes data from the recovery trial. And the premise for this study was that it was really being increasingly recognized clinically that there was a subgroup of patients with COVID-19 who really had a severe inflammatory response that was associated with high levels of inflammatory markers, things like CRP, ferritin, interleukins, and really severe end organ damage as a result. And so there's some data in other infectious respiratory conditions where dexamethasone was thought to be useful, but in other cases it was actually seen to be harmful. So this study was done to figure out what is the role of the use of dexamethasone for patients with severe disease from COVID-19. So this is a UK-based trial, and people were randomized 2 to 1 to receive either the usual standard of care alone or standard of care plus dexamethasone, either oral or IV. This trial, the primary endpoint was all-cause mortality at 28 days after randomization, and it was stopped early because this was the first drug to show mortality benefit in this population. And you can see from the figure on the right that in the usual care group, mortality was about 26%, and in the dexamethasone group, it was lower at 23%. But you can also see clearly visually here who benefited the most. And so you can see here it was either patients who were ventilated or on oxygen but not ventilated. And then similarly, you can see in patients who had milder disease who were not on oxygen that they actually had an increased risk of mortality about 19% increased risk in adjusted analysis. So clear benefit here for dexamethasone in those who were requiring oxygen and had more severe disease. So these findings were supported by subsequent meta-analysis, and this looked at 7 randomized controlled trials. This was published in JAMA subsequently. But again, the impact of steroid administration and the outcome was 28-day mortality for critically ill COVID-19 patients. So this looked at patients who were in the ICU, required mechanical ventilation, and or required a substantial amount of supplemental oxygen, so at least 6 liters a minute. And it also looked at a combination of patients who were receiving different types of steroids, so dexamethasone, hydrocortisone, methylprednisone, either at higher dose or at lower doses. And so the forest plot on the right of this graph shows that almost all of the studies clearly favored steroid use and did not cross that kind of null line where the odds ratio is equal to 1. The overall estimated effect of steroids as an intervention for this critically ill group was a reduction in mortality of between 30 and 34%. So significant benefit of steroids, again, in a multi-site meta-analysis, meta-analysis. So moving on now to IL-6. So interleukin-6 is released in response to infection and stimulates inflammatory pathways as part of an acute phase reaction. And tocilizumab and sarilumab are monoclonal antibodies against the IL-6 receptors, and they are used to treat other inflammatory conditions. And so this trial, the REMCAP trial, was a fairly complicated, pragmatic trial where patients were randomized to multiple interventions across a variety of domains. So they could have been randomized to get an antiviral and an immune modulator. The bottom line is that for this analysis, the primary comparison was between these IL-6 inhibitors, tocilizumab and sarilumab, compared to a control condition, and all but 3 of the patients in this trial had acute respiratory support with at least high flow nasal cannula, so they were more ill. The primary outcome was the number of, it's a little bit complex, the number of respiratory and cardiovascular organ support-free days at day 21. And when you look at the outcomes here, both of these agents, tocilizumab and sarilumab, were associated with improvement in that primary endpoint and also an improvement in mortality relative to the control group. So this is additional data from the recovery trial looking at tocilizumab, which this is the trial we described earlier. They had a comparison of tocilizumab versus usual care. And at this point, usual care included steroids because we've now already seen that benefit. So 82% of patients were on steroids. And this was for patients who had hypoxia and evidence of systemic inflammation. So all of these patients had a CRP that was greater than or equal to 75. And you can see here the outcomes on the right. Improvement in 28-day mortality, improvement in progression to invasive ventilation or death. So this forest plot also shows the benefit of tocilizumab over usual care across most of the subgroups looked at. So days since symptom onset, the type of respiratory support they were receiving, and the use of corticosteroids. So now let's talk about another immune modulator, Paracetam. Paracetam is an orally administered selective inhibitor of a molecule called Janus kinase, so JAK1 or 2 inhibitor. This was actually predicted to be of potential use in the treatment of COVID-19 using artificial intelligence algorithms, but it inhibits a signaling pathway of cytokines that are known to be elevated in severe COVID-19 disease, including things like IL-6, IL-10, interferon gamma, and other factors. So there are two trials summarized here. Act 2, which randomized over 1,000 patients to Paracetam plus our friend Remdesivir versus placebo. And in that group, they found people who got Paracetam plus Remdesivir did better than those who had placebo alone, except if they were on mechanical ventilation. Importantly, it did not evaluate the effect of Paracetam with corticosteroids, so that's an important limitation. And then the COVID barrier trial looked at patients receiving standard of care, which was Remdesivir in 19% and corticosteroids in about 80% of patients. That's the data that is on the figure on the right. So you can see the primary endpoint there was death or progression to needing more advanced support. And the secondary outcome was all-cause mortality. So you can actually see improvement in that secondary outcome of all-cause mortality in the COVID barrier trial. So with all of this, what do the NIH and the IDSA say? So these are the most recent recommendations for Paracetam and tocilizumab. The NIH says that for hospitalized patients, they recommend either tocilizumab or Paracetam, which we affectionately call Toci and Barry at my institution, in combination with dexamethasone alone or with Remdesivir for patients who are having more severe disease, high flow oxygen, or non-invasive mechanical ventilation, with evidence of progression of inflammatory markers or rapid progression of severe disease. Also, importantly, Paracetam has been used also and recommended as a steroid substitute. So in patients who cannot receive corticosteroids, you can use Paracetam and Remdesivir in combination in patients who are not intubated but require that supplemental oxygen. So think of it as a steroid substitute, that combination of Paracetam and Remdesivir. Similarly, IDSA says that for patients with severe critical disease on high flow O2 again, or non-invasive ventilation, Toci or Barry, in addition to the standard of care. So this is actually a visual which may be helpful. This is just the NIH recommendations. So hospitalized patients but don't require supplemental oxygen at all, we're really providing a supportive care here. Remdesivir may be appropriate if they are progressing to more severe disease. If they're hospitalized and require supplemental oxygen, we have data for the use of Remdesivir, dexamethasone plus Remdesivir, and then dexamethasone if Remdesivir can't be used, you can use dex alone. If they are requiring oxygen, high flow oxygen, or non-invasive ventilation, similarly, this is where you can add on tocilizumab or Paracetam potentially if there's evidence of systemic inflammation. And then remember that combination, Paracetam plus Remdesivir, can be used as that steroid substitute. So always keep that in mind. And then the patients who are hospitalized and requiring invasive mechanical ventilation or ECMO, this is where really we have data for dexamethasone plus tocilizumab. So that's really your go-to for those with the most severe disease. So we're going to circle back to this important conversation. We know, as we mentioned earlier, that most patients who are infected with COVID-19 disease have mild disease, but those 20% or so who have severe disease end up in the hospital and can have bad outcomes. Those are the ones we've just summarized. But we see that disparities exist all along that continuum by race and ethnicity. We highlighted earlier, Chuck highlighted earlier in the talk, that racial and ethnic minorities have a 1 to 2 times increased risk of infection, 2 to 4 times increased risk of hospitalization or death from COVID-19 compared to non-Hispanic whites. And these disparities have really amplified much needed conversation and discussion on the importance of addressing drivers of structural racism in medicine and public health and important social determinants of health. So I'm going to hand over to Chuck to talk about some of this data from New York.
Yeah, thanks. And thanks for the great summary on treatment. It's worth thinking about, what are some of the underlying causes, and there is some data out there, and as everything else with COVID-19, it is changing. But this is a study done from the experience in one major center when New York was undergoing a real crisis with COVID-19, seeing a ton of cases. With a diverse patient sample, you could see that, as we've discussed, folks who are either Black or Hispanic had higher rates of a positive test for SARS-CoV-2 and were more likely to be hospitalized. Could there be a problem as well with the way we take care of patients, once they are diagnosed, once they are hospitalized with COVID-19? We certainly know there's a lot of disparities in terms of the way we treat patients based on race and ethnicity, pain control being one. Getting procedures such as cardiac catheterization will be another. And those are well established. In this study, they showed that actually on adjustment for comorbidities, folks who are Black and Hispanic actually had a lower risk of mortality. So this study would suggest that that's really are those social determinants of health that are driving folks into the hospital from Black and Hispanic communities. But it is contradicted by a study that was just published in JAMA Network Open yesterday. And this is a much larger study looking at Medicare enrollees across the country, 40,000 plus of them. And what it showed was that that individuals who were Black actually did have a higher risk of in-hospital mortality, and that it had something to do with the way they were treated. And this is it's a retrospective cohort study with modeling, but still it did suggest that essentially that if Black patients were treated in hospitals where there was predominance of white patients, their risk of mortality would not be elevated. So we always have to be introspective and think about the way we take care of people. And, certainly when I see patients with multiple barriers to care who come from poor backgrounds, who have, a fairly low index of understanding, even as they're critically ill, and not necessarily getting the information in a way they can understand in the language they prefer to speak, that's somebody we really have to reach out to and go that extra effort to try to treat them better. Because it's not just this one study. I will let Aima talk about this study from another academic center in Milwaukee, Wisconsin.
Thanks, Chuck. So this study, the objective of it was really to look at the association between race with incidence and outcomes from COVID-19 when controlling for a number of factors. So we try to control for age, sex, socioeconomic status, zip code, and other medical comorbidities. So it was a cross-sectional study. It was about 2,500 patients. This is the largest academic system in Wisconsin. So it was multi-site within Wisconsin. In the study, they found that Blacks had 29% of Blacks had greater than or equal to 3 medical comorbidities, and that was a little bit higher than in the non-Black population. Poverty status, there was much more poverty in the Black community compared to those who are non-Black in this cohort. Interestingly, though, when they adjusted for, a lot of these factors, including zip code, socioeconomic status, et cetera, what they found was that COVID positivity remained associated with Black race, with male sex, and with older age. Hospitalization, on the other hand, was associated with Black race and poverty. And then ICU admission was associated with poverty, but not Black race. So I think data like these and like the one from New York, it can be really complicated to tease out the relationship between all of the kind of socioeconomic and social determinants that we're trying to, that we know are likely contributing to disparate outcomes. And so I think we're seeing different things slightly and different in different settings, depending on the study approach, what they're able to model, what they're able to account for. But at some level, we know that race, that poverty status, that socioeconomic status are influencing at least some of these outcomes. We'll go back and talk a little bit about place.
Yeah, I mean, it actually influences the the most important outcome of all, which is overall mortality. And think about the neighborhood, and the area where you live, and you probably know about the health disparities that are regional or local to you. And it's the difference between life or death for many folks. This is research that looked at central New Jersey and looking at different zip codes and life expectancy, and you could see that just a difference of 19 miles between places accounted for 14 years. And it's not the geography that's a problem here. It's the fact that there is more poverty in Trenton, that there is more disadvantage, there's higher risk of severe violence, et cetera. And those are the things that lower life expectancy overall. And this isn't just in New Jersey. This has been demonstrated in Baltimore, Maryland. It's been demonstrated in Alameda, California. And it's something I think we all know intuitively, and there is good research to support it, but it's just that COVID-19 has really drawn this out and made it more of a national issue that even folks who are not in healthcare are paying attention to these days. And that has a lot to do with the social determinants of health. I'd like Aima to comment on that.
Great, sorry, I advanced that slide a little bit too early. So we've mentioned this, we've alluded to this already, and social determinants of health really has a kind of broad scoping definition. The World Health Organization describes social determinants of health are conditions in which people are born, grow, live, work, and age. So everything around and about us. And so as you can imagine, it can be conceived of in a number of ways. This is one helpful way to look at the different categories of social determinants, things like economic stability, neighborhood and physical environment, including that zip code that, or exactly where you live, like Chuck just mentioned. Education, Chuck mentioned this as well, literacy, language, the ability to communicate well with our patients and promote health literacy, access to food. Of course, food security, if you're food insecure, you may not really be focused on anything else. That may be the primary focus. Community and social context, and those are things like discrimination and stress. And then the healthcare system itself. Do you have access to healthcare coverage or to providers or to linguistically and culturally appropriate care? And so, really growing evidence supports the role of each of these social determinants on important health outcomes. And, of course, all of this discussion, as we mentioned, has really been amplified in the context of COVID-19. But I think that when looking at a figure like this that really enumerates the breadth of social determinants, what they are, it really kind of calls out to us that the types of interventions we need to address these types of disparities are structural, they're scoping. So, there's some large kind of frame shifts in how we administer healthcare on a public health level, on an individual level, that need to happen to really address these outcomes in a better way. And there are a couple of thoughts here from different leaders in the field highlighting these comments. I'll just pause so you can see these important quotes. I'll give it back to Chuck to close out on this topic.
Yeah, thanks for sharing that. So in summary, we talked about the disparities based on race and ethnicity. It does come down to the poverty, to the lower educational status, to living in difficult conditions, and so there's structural racism and violence that have been present for a long time. That's really what's driving these higher rates of hospitalization mortality in these communities for COVID. We also talked about treatments. So remember the monoclonal antibodies, you want to apply them to folks who are at least 12 years of age. It's for outpatients only, and they have to have high risk of disease. Remdesivir is a good treatment for inpatients, particularly if they are on oxygen support but not on mechanical ventilation or ECMO. You want to start these treatments in terms of antiviral therapy, which includes all those monoclonal antibodies, as soon as possible. And dexamethasone has been associated with lower mortality rates among patients with more severe COVID-19. I really like the slide you shared, Aima, with the recommendations kind of one by one based on severity of inpatients. I think that was really helpful as a summary. But that's just part of the story. I think it's also, as we've described, really getting to know patients. And when we talk about social determinants of health, it's natural to feel overwhelmed. Like, how can I make a difference in all these things? Well, you can apply it the way you take care of individual people. You can account for those factors. And then on a larger level, I hope we can all stand as advocates and allies, in trying to create more structural change and frame shifts, as Aima describes, to make a difference. And it does come down, it starts with individual patients and their experience. And so we do have a video that talks about one patient story, and I think it's particularly telling.
I really was feeling bad and I knew something was wrong. So when I did wake up that Friday morning, I drove myself to the ER. The doctor came and she said, "We can send you home on some oral antibiotics." I said, "If I stay here, will I get the antibiotics IV?" And she said, "Yes." And I said, "I think I want to stay." But I did that because I was scared. The nurse that was taking care of me that day, I requested to her that she contact the doctor because I had been on every antibiotic and my temperature was still 104. And he said, "We're going to test you for a respiratory panel, we're going to test you for HIV, and we're going to test you for the coronavirus." I just hear someone screaming in the hallway. And I told my girlfriend, I said, "That's my mom." So my girlfriend gets up to see, was that really my mom? And when she got up and went out the door, a security guard came and slammed the door closed. And I'm banging on the window, trying to know what's going on. The security guard kept his back to the door the whole time. I turned the wheelchair around and I looked up at the television.
We are told, in fact, that there is a person who is being treated in New Orleans that is from Jefferson Parish right now.
This is a person who has contracted the coronavirus. They are from Jefferson Parish, but again, they are at the VA hospital in New Orleans getting treatment right now.
Who do you think that was?
Thank you so much to both of you. We are going to move into the Q&A now and answer as many as time allows. To honor everybody's time, we will keep this brief. But the first question is, and I'll give this to Dr. Ahonkhai, when should Remdesivir be initiated?
So I think, like all of the antiviral interventions we mentioned, as soon as possible after admission, and they have to have technically had their COVID-19 diagnosis within 10 days, so the positive either symptomatology or PCR test.
Great, thank you. And the second question, what about inhaled steroids? Are those helpful for ambulatory patients?
Well, there is some promising but early and preliminary data about the use of inhaled budesonide. It does have a mechanism for why it might be able to help patients when they're infected with COVID-19, and there is some positive outcomes in terms of reducing further healthcare use. But it's not recommended, I think, for routine use at this time, pending larger trials which are ongoing. So inhaled steroids, is a possibility that might be something that we could be using more broadly in the near future.
Okay, and this one I'll just toss up. Third question is, can someone who received the vaccine but then gets COVID-19 still use monoclonal antibodies for treatment?
You want to start, Aima?
Yeah, there's no contraindication with regard to getting the vaccine. I mean, there is the thought that if you've had COVID-19 disease or monoclonal antibodies for treatment, especially in the earlier phases of vaccine scale up, when we know you still have some likely short-term protective effect, then we wanted to prioritize people who had no protection from COVID-19 for getting vaccinated. But in terms of the opposite way around, if you're vaccinated and you've still gotten ill, you can still be eligible for monoclonal antibodies if you meet the criteria.
Okay. Thank you again to both of you for joining, and thank you to all of our learners. To our learners, if you'd like to claim credit, please do click the claim credit button that will appear at the webcast end, and be on the lookout for our 30-day survey. You'll receive that through email. As always, your responses will help us develop further education. Thank you for joining us. For those questions that we did not get to, we will do our best to incorporate those into upcoming webinars, so please do stay tuned for that. Thank you and have a great day.